My name is Sheng, one of the faculty at Boston Medical Center. I'm very excited for the opportunity to be here today to try to answer this very important question. How much of that CT, the one you're going to get right when you get back to your shifts, how much does it really matter? I italicize that right there. And first of all, nothing to disclose. And I became interested in this topic when I read this article in 2014. Anyone else remember the headline? Let me jog your memory with an excerpt. Can you guys see back there? So, raise of hands. How many of you routinely order multiple CTs before even meeting a patient? I hope I created a safe enough learning environment that you guys will be willing to volunteer. But right, and I was a little bit irked by the way emergency medicine was portrayed. And this radiation technology student in 2007 won an award for this article. I'll let you read the excerpt as well. Where in his extensive experience caring for trauma patients is criticizing CAT scanning, which I get, it's controversial. And if any of you know what this let's do a quick CT approach to emergency medicine is, please share with the rest of us. They can help my RVUs, help all of our RVUs, right? But unfortunately, this is what the public's reading, so we have our work cut out for us. Here are objectives. We're going to describe the rise of radiation exposure due to medical imaging and some of the projected cancer risks. We're going to look at the doses of common things we order in the ED. We're going to define this linear no-threshold model and explain why it's good, why it has some controversies. And then we'll look at some of the conflicting basic science and epidemiologic evidence concerning our particular risk. Let's start with the case. 24-year-old male coming in for 1 day of colicky left flank. Sounds like kidney stone. He's never had this before. Urine shows some red blood cells, no whites. Creatinine's fine. Raise of hands. How many would get a CT? First time kidney stone, maybe. Okay. How many an ultrasound? Really? No.
I would do an ultrasound. I wouldn't get one.
Oh, you're not a consultative ultrasound, so I get it. How many? Nothing at all. Just treat it like a kidney stone. And I know as emergency medicine physicians, you guys are already considering the benefits, the risks. And this is what the meat of this talk is about. What are those radiation risks, and where do we get those estimates? Let's start with some recent trends in imaging utilization. These are the number of radiology procedures in the millions. And just from 1980 to 2006, they've increased drastically, increasing the ionizing radiation exposure to the general public by about 6-fold. CTs obviously have gone up drastically. Just from 1993 to 2006, they've increased about 4-fold to up to 80 million scans annually. And we know that up to 75% of medical ionizing radiation come from CT. So it's a big culprit, and we're going to focus. In ED, we're really ahead of the curve. We have the CT use have increased at a much faster rate than other imaging modalities like X-rays or ultrasound, and at a much faster rate than any other setting, like inpatient or outpatient settings. We've increased at a rate of 16% a year. Just from this study period, 1995 to 2007, they've increased 6-fold. However, maybe we're starting to see a plateauing or even a downtrend in overall CT. This is not just ED. This is in Medicare beneficiaries. But if you look at it closely, everyone else is starting to plateau, maybe even downtrend, but we're still working hard, making those, I guess those RVUs. But this study projects, this shows the number of CT scans done by age group in the millions in 2007. And the same study projects this many cancers as a result by age group. And at least initially, most of the efforts have been trying to reduce CT use in pediatric populations. And rightly so. They undergo more mitoses, their tissues are more radiosensitive, and they have more lifespan years to manifest those mutations. But if you guys had to look at this graph and look for where can you get the biggest bang for your buck, the biggest public health impact, where should we also focus? In adults, right? Age, at least in this graph, 35 to 64, because of the high frequency use. And it generally takes, people estimate, 1 to 2 decades before a single radiation exposure could potentially manifest as cancer. It could be as little as 5 years, and people are living a lot longer these days. Same study estimates that up to 29,000 future cancers could be caused by CTs performed in 2007. That's 2% of all cancers diagnosed. Assuming a 50% mortality, that's 14,500 cancer deaths. And you'll see other numbers quoting that the risk of getting cancer from a single CT could be as high as 1 in 80. We'll talk about that. But I'm not here to bash CTs. In fact, we know there's a favorable benefit to risk ratio in the use of CTs in symptomatic patients, which pretty much all our patients are. Imagine the workup and treatment of trauma, stroke, vascular conditions, cancer without CTs and CTAs. And God forbid we take anyone to the operating room these days for appendicitis without a CT, right? This is eliminated exploratory surgery. So those are the benefits. And there are risks as well. Ionizing radiation is uniquely energetic enough to knock an electron out of orbit, causing one or more of these electron tracks. I'm going to keep this really simple, this molecular stuff, which can go on to cause double-stranded DNA breaks. And since the number of electron tracks is directly proportional to the radiation dose, it's thought that no matter what dose, no matter how small, could potentially cause cancer. And while most radiation-induced DNA damage is rapidly repaired by your DNA repair mechanisms, an occasional misrepair could lead to point mutations inducing cancer as well. And there's many different ways to quantify radiation exposure, and it's very confusing. Radiologists and physicists prefer the term effective dose, or measured in sieverts, or for us, millisieverts, that describes a non-uniform exposure to the whole body, and is much more useful in talking about the risk of cancers, genetic mutations, because it allows for a rough comparison between different imaging scenarios. But nevertheless, it's still pretty rough estimate of actual true risk. Now let's look at the common ED test we order. I'll let you look at it for a second. At least at a level of 0.02-ish millisieverts, X-rays are relatively small fish, at least for adults. CTs, on the other hand, poses hundreds of times more radiation, therefore much more significant. And keep in mind your nuclear medicine tests, like your nuclear stress with imaging, your VQ scans, do have some small but significant radiation doses attached to them as well on the level of CTs. And this table from Academic Life and Emergency Medicine translates those effective doses into lifetime attributable risk of cancer, based on projections by Smith-Hyman, the one who wrote the New York Times article. Meaning your chance of getting cancer from one of these CTs is 1 in whatever 100, whatever 1,000. Just to get a ballpark of where things are at. And obviously, as the risk decreases as you get older. Now, what is the epidemiologic evidence supporting any harm? They come mainly from the Lifespan study, which followed over 120,000 survivors of the atomic bomb blast in Japan. Big study, robust study, huge sample size. We've been following these victims for over 70 years, long length of follow-up. The breadth of the population exposed was wide, from the infants to the elderly, and the range of doses exposed to was wide as well, from very small doses to lethal doses. And all these factors allow the risk of most solid cancers and leukemias to be estimated. An analysis of the survivors exposed to as little as 100 millisieverts, keep that number in mind, 100 millisieverts, shows that cancer risks at these lower dose ranges were consistent with linear estimates from much higher dose range exposures. So in other words, we have solid data from atomic blast survivors exposed to as little as 100 millisieverts. That shows that cancer risk has a linear relationship with effective dose. But below 100 millisieverts, however, any increase in cancer risk is just too small to be picked up from just kind of background incidence and prevalence. So multiple projection models have been proposed, lines 1 to 4 here. The most widely accepted model based on previous molecular data is the linear no threshold model, linear no LNT, which supposes that the response to radiation is linear. What happens at higher doses can be extrapolated all the way down to lower doses, and there's no threshold at which cancer may not develop. But since we really don't know for sure what the shape of the dose response curve is, that dose is relevant to us, right? Like 100 millisieverts, what? 8, 10 belly CTs based on the graph we saw earlier, or the table we saw earlier. The linear threshold model has its critics. They argue that the principal data source, the atomic blast survivors, are very different from our patients. And it's true, these unfortunate victims were all from the same country. They had similar incidents of colon cancer, breast cancer. They were very different from our populations. And then also they were just going about their business when a single exposure hit them. Very different from the context that we use CTs for. And this is a picture of a macrophage injecting toxins into tumor cells. And we know from clinical experience that when you suppress someone's immune system, like in transplant patients, there's an increase in cancer risk. And so the immune system must play some crucial role in cancer prevention. And in fact, we have some non-human in vitro studies showing that low-dose radiation may actually be beneficial in terms of preventing cancer by increasing surveillance of tumor cells, a process called hormesis. And there's some small studies of British radiologists who entered the National Health Service in 1955 to 1977, and they were exposed to some low levels of radiation at the beginning of kind of radiology, and it turns out they had a decreased cancer risk compared to the general population, so maybe it's not so bad. Now let's look at these estimated cancer projections. These are scary, scary numbers. They're computed by sometimes multiplying controversial risk factors by huge populations to yield impressive numbers of cancer victims. They don't always take into account the age, sex, comorbidities, genetic factors at time of exposure, or the environmental factors that might influence risk afterwards. And most CT radiation-induced cancer projections assume perfect health, great longevity, when our patients who are getting CTs are much more likely to be older, sicker, vastly reducing the potential impact of these CTs. Now, with all this back and forth, where are we, right? You got, on one hand, there's molecular damage showing, yeah, maybe there's risk at any level, and then the lifespan study certainly supports that, the linear no threshold model. But we criticize that study. We have issues with these cancer projections. We have thought that maybe some basic science studies of hormesis may actually be protective at low doses. So keep in mind that most of the basic science studies opposing the linear no threshold model are based on plant, algae, protozoa, fungi, and it's unclear whether these experimental endpoints are relevant at all to in vivo human cancer. And despite the limitations of the lifespan study, the results are actually generally consistent with some other smaller epidemiologic studies of occupational radiation workers who were actually exposed to less than 100 millisieverts, showing that there is a small increase in cancer risk. So let's summarize. Ionizing radiation exposure, obviously, from medical imaging, especially CT, has exploded. Keep in mind, results matter too, right? People are living a lot longer. Generally, the benefits are worth the risks. And there's limitations of all of the evidence that I've summarized. The linear no threshold model is a conservative model, but what it does is extrapolates the risk from what we know fairly for sure, from higher dose ranges to lower dose ranges. And there's a majority of not universal consensus regarding that model. So now that we have a better idea of the evidence behind our concern, let's try to answer our initial question. How much does that CT really matter? I think the definitive answer is that we just don't know for sure right now at doses relevant to us in medical imaging. And I know that's not satisfying. But with that uncertainty, I do think the reasonable approach based on the linear no threshold model is to assume a potentially small risk that definitely adds up in a cumulative fashion as we approach that 100 millisieverts mark, as your chronic abdominal patient gets that 8th or 10th belly CT. And I think this quote from the British Journal of Radiology summarizes this quite well, that it's reasonable to err on the side of caution when there's uncertainty, yet not unduly alarm patients who may have much potential benefit from the applications of diagnostic imaging. Thank you. Questions? Yes?
So as far from the benefit side of the equation, this is clearly mostly about risks, but
Yep.
I've experienced for 10 years, so my sample size is much less than a lot of other people in this room. But I've been struck by how many times over 10 years, not a daily occurrence, they found something completely unexpected that actually was beneficial. And I wonder, for example, 1 in 1,000 people have renal or kidney, or just a sole kidney. And if they did have a kidney stone, it would have been more emergent, or maybe a Meckel's diverticulum, or once I found a toothbrush unexpectedly in the stomach. And so I think all of our gestalts goes into this, the internal map, the unexpected that we have come across. And I haven't seen studies that have addressed sort of a comparison of the unexpected benefits versus the unexpected risks. So maybe it exists, I don't know.
So there's no evidence. So our audience member is curious talking about incidentalomas. And some of them can be important and relevant, but there's no good studies addressing what those impacts could be. And obviously sometimes, there's the other end of it where they become what we call vomit, victim of modern imaging technology, where we find something, they undergo a whole slew of tests they never really needed, and then cause a lot of distress, costs, and harm potentially. Any other questions?
What about newer machines that use less radiation?
So that's one thing I didn't cover, obviously, in this small talk, but radiologists and physicists work very hard to optimize imaging doses, especially for pediatric populations. In most large hospitals, I mean, the doses for CTs used to vary drastically. You would get, 25, 30 millisieverts from one hospital for a belly CT and get 10 in the other. And they've done a very good job standardizing those doses as technology evolves.
I don't know if you ever looked at this, but there's a website, xrayrisk.com, that uses the linear model, and you can plug in your age and all the CTs you ever had, and it'll give you the background risk and then the risk above that.
Yeah, there's quite a few different risk projection models out there on the internet already. Yeah, and that's definitely the one. Thank you, guys.
So, and I'm a fast talker, so tell me to slow down. I initially thought my talk was 40 minutes, but it's case-based, so we can just do the cases and be done when we're done. And every year I try and talk about something different, because Dr. Weimer always says, talk about whatever you want. So I'm going to talk about some tick-based stuff that you guys could all see in the ER, some of them are a little more unusual. I'm not talking about Lyme disease, that is my disclaimer. So here we go. So 50-year-old, I may just stand down here. So 50-year-old woman comes to the ER with fever. She has headache and some myalgias for the last 3 days. She has no nausea and vomiting. She traveled from North Carolina to Vermont to bring her son to UVM, so it's August. She recently returned 8 days ago from Kruger National Park in South Africa, where she did a safari. She was really good. She saw her infectious disease consultant beforehand and took her Malarone. She just completed her week at home. She got all her pre-travel vaccines. On exam, she's febrile, she's tachycardic, and she has this rash. She has a diffuse maculopapular rash with some areas of vesicular component, and then an area of sort of like coin-sized eschar that she noted. And then when you examine her, you note 2 other areas of eschar with associated adenopathy. And so that's not her, but that's what the eschar looks like. And she has 2 other areas. She's got a mild transaminitis, a little bit of a leukopenia, but otherwise nothing's really remarkable on her labs. So you guys don't have clickers, so I apologize, but anyone that's brave, so most likely etiologic agent of her infection. Obviously, it could be lots of things in a traveler, but what do you think? B, Rocky Mountain Spotted Fever. Okay, because she comes from North Carolina. Okay, anyone want to say anything else?
African tick bite fever.
Okay, African tick bite fever. Okay, it's definitely not Lyme disease because I'm not talking about Lyme disease. So this is actually a not uncommon cause of fever in the returning traveler, and it's African tick bite fever, and it's tick bite again in Africa causes fever, and it's Rickettsia africae. And unlike some of the other tick-borne illnesses, it doesn't tend to make people quite as sick. But the hallmark finding for this is multiple areas of eschar with associated adenopathy. So things like Bhutanese fever, it's a tick-borne illness in the Mediterranean littoral. You can get an eschar. There's a type of tick-borne disease in parts of Asia where you can get an eschar. But multiple areas of eschar with associated adenopathy is almost always, with the right history, African tick bite fever. The diagnosis is clinical because you can send serology, you can send PCR, but by the time you get that stuff back, you've probably already treated your patient. And treatment of choice for most all of these things is doxycycline. There's very few exceptions to tick-borne illness and doxycycline, which is what I tell the infectious disease fellows, and there's few exceptions to GI, like nematodes and trematodes and praziquantel. So if you know those two things, you're pretty much an ID fellow in the making. But doxycycline, or if your patient's allergic, 750 twice a day of Cipro, chlorithro, and erythro are acceptable alternatives. And we'll talk about that. There are very few exceptions in terms of doxycycline treatment for these tick-borne illnesses, but this is one of them. Okay, and I will say my timer's not going, so I don't know if it's supposed to go, but okay, there we go. It's like when I yell
more
at the rest
time.
that the clock's not going for my kids' basketball game. 26-year-old man who comes to the ED with fever and rash. He's been touring with Fish, and he recently returned from Portland, Oregon, which I think touring with Fish puts you at risk for all sorts of things in my experience. But he was camping outside, cooking over an open fire. He was smoking lots of marijuana, he says, and occasionally using inhalation or cocaine. He had several episodes of unprotected sex with multiple female partners during his tour. And he comes with 2 days of fever, headache, myalgias, lethargy, but also some nausea, vomiting, and abdominal pain. I'm sorry, it's a little tiny, but on exam, he's hypotensive, he's tachycardic, he's febrile, he's jaundiced, some scleral icterus. He has some mild abdominal tenderness throughout, no appreciable splenomegaly, and he has a well-healed scar kind of on the right side of his abdomen, and he has this diffuse, very mild erythematous rash. On exam, he's got a little bit maybe of a leukocytosis, he's anemic, thrombocytopenic, transaminitis, and his bili's 6.2, and his creatinine's up a little bit. So he gets scanned because of the abdominal presentation and his vital signs. And there's really nothing notable on the CT except that there's no spleen where there should be a spleen. So, asplenic patient comes to your ER. The most likely etiologic cause of this patient's severe illness is which of those following?
D.
A.
D.
Strep pneumo. D. Capnocytophica canemorsis. The dog bite, yeah. C, okay. I love it. And so it really could be any of those things, right? So if you didn't know that this was the tick bite talk, it could be any of those things. And probably in order of importance or most common things, it's strep pneumo, Neisseria, and then all these other things. But it's C. So remember, we talk about the risk of encapsulated organisms for post-splenectomy sepsis. So H. flu, pneumococcus, and Neisseria. But Babesia is a disease that causes, or a parasitic disease that causes post-splenectomy sepsis in asplenic patients. And that's really important to remember. For us on the East Coast, it's mostly Babesia necroti, and there's no reason you need to know this in terms of microbiology. But on the West Coast, there is B. duncani, and it causes disease most severely in asplenics. In Europe, there's a divergence, and we're seeing a new kind of babesial species in Washington. We are calling it divergence-like. Again, these aren't things that you necessarily need to know all of these names. How do we diagnose Babesia? The most common, the first thing we start with is a peripheral smear, just like we do with malaria. There's PCR and there's serology. The CDC recommends that we do smear first, and then if your smear is negative, you can go on and do PCR and serology. And I will say that if you look at these peripheral smears, these red cells under the microscope, if you don't know the travel history, this looks just like falciparum malaria. So important to ask your patient about travel history, because obviously that's a very different treatment algorithm. An experienced microscopist could probably tell you the difference, but it's really hard to tell because they both make those delicate, beautiful little ringed worms that you see there. And I always say that there's a lot of things, but I think about pancreatitis as this big spectrum. Like you could have a titch of pancreatitis, or you could die from pancreatitis. And Babesia is one of those funny things too. Most people are going to be asymptomatic, and when they do serologic surveys in places like Martha's Vineyard and Nantucket, there's a high prevalence of seropositivity to Babesia, so it doesn't make everybody sick. The risk factors for severe disease in your population are HIV patients, patients over 50, patients without a spleen. Those are the biggest risk factors. The disease itself is pretty non-specific, right? It's fevers, myalgias, and body aches. It doesn't really have anything that says, oh, that's clearly babesia. It's non-specific. So you have to ask about a travel history, and you have to have a high index of suspicion. We have a high incidence of IV drug use now in the country, and particularly for those of you guys are on the front lines in the ER and urgent care, you see a ton of these patients coming in. I will say that babesia can cause Janeway lesions, splinters, hemorrhages. They can cause splenic infarcts, renal infarcts, cerebral infarcts, just like malaria does. So in the right clinical scenario, it can look like endocarditis as well, and that's an important thing to consider. These folks can get ARDS, they can get splenic rupture, DIC, autoimmune hemolytic anemia. It can be a really severe, complicated disease. And I will say that in terms of other things to think about, it can be passed transplacentally, so from mom to baby, and it can be associated with blood transfusion. So my colleagues laugh at me because we see these neutropenic patients on the oncology floor, and they're febrile and have an ANC of like nothing for weeks and weeks. And I'll start sending them little smears looking for transfusion-related babesia, but I'm going to find it one day, but I have yet to see it. So I tend to send a lot of those. So important to think about who is at risk for severe disease, and this was a nice article from the American Journal of Tropical Medicine and Hygiene, thinking, are there things that we can look at on presentation that might make us think we should be hospitalizing certain patients with babesia versus just sending them home? And I think that this is tiny. The important things to take away from this are people that present with nausea, vomiting, and diarrhea, or asplenics, or a bilirubin over 1.6 or 1.9, are indicators that those people are at risk for developing severe disease and should probably require hospitalization. So if you guys are thinking, do I need to call the hospitals to admit this person, or can I just send them home? Those are important things to think about, and this was a really nice review. Okay, so you guys are waiting for the hospitalist to come down and admit this patient. So I would ask you, A, I guess, do you want to start treatment? And B, if you do, which of those 4 things would you start? Someone said D. Okay, great. So I come across this a lot where people say, well, they have babesia, so we started them on doxycycline. This is one of those exceptions to the tick rule, is that doxycycline has no role in the treatment of babesia, and that's really important to remember. So azithromycin and atovaquone, which is sort of a hard thing to remember, or clindamycin and quinine. For patients that might require exchange transfusion or ICU level of care, we would give them quinidine because it's IV, just like we would for malaria. But yep, azithromycin and atovaquone, just remember doxycycline has no role whatsoever in the treatment of babesia.
Is it the same stain, the same procedure when they look for malaria, or different?
Yeah, that's a great question. So now we do 2 things for malaria. We look at what's called a point of care testing. It's this little card that we put a drop of blood on, just like we would for Legionella urine antigen or strep pneumo urine antigen. And it will tell you within minutes, Plasmodium falciparum, mixed, or other. So we do that for malaria, and then we do the smear. For babesia, they don't do that card. So it's the exact same. We make a thin smear to see the level of parasitemia, meaning how many red cells have a little organism or are parasitized. And then we do a thick smear that helps us determine what the species is, and that would be for malaria.
So if you were to order a malaria smear and someone had babiosis, would they find the babiosis?
Yeah.
Okay.
Yeah. In our hospital, we call it peripheral blood smear for parasites. It might be different at your institution. And your lab might call and ask you and say, are you looking for babesia? And on our order set in PRISM, we click, check here if you're looking for babesia. Because that means they won't do the little card. But it's a great question. It's exactly the same microbiologic technique. And this is an old study from the New England Journal. I'll just put this in to say that when they looked at treating patients with clindamycin and quinine versus azithro and atovaquone, overall folks did pretty much the same. There was a little bit longer time for clearance in terms of PCR clearance in the clindamycin group, but I will say they did not include anyone in this analysis with severe or life-threatening disease. So really, if you can give someone azithro and atovaquone, that's the preferred topical, it's not IV, so that's a little complicated. People are really sick. And like all good things that come to an end, we are sort of worrying now about maybe some azithromycin resistance in babesia, which will be a huge problem in terms of treatment. This review looked at only 3 patients who had relapsing disease, and they were worried about azithromycin resistance, and they did find documented resistance, but I will say that plenty of people relapse, especially immunocompromised patients need multiple courses of treatment. It doesn't necessarily mean they have resistance, but this is something that we are talking about more and more. Okay. Had 3 cups of coffee today, so I'm fast talker, so sorry. So 26-year-old woman comes to the ED with fever and rash. She's 34 weeks pregnant, and she recently went home. She's a Tar Heel. She went home to attend a wedding in Chapel Hill. And she said her symptoms just started yesterday, non-specific stuff, but she does have some vague abdominal pain. And the wedding was outside. There were a ton of guests. I was exposed to a lot of people. They were outside most of the day, and she couldn't recall eating anything weird, and she couldn't recall anyone else that was ill. Hopefully there are no Duke fans in the room. Sorry about that. And so this is what her rash looks like. This is just part of her rash, but it's all over her body. It's not vesicular, it's non-pruritic, it's not petechial. So given the clinical history, given the fact she gave in North Carolina, we suspect Rocky Mountain spotted fever. She's 34 weeks pregnant, so I would ask you, which of those things would you administer to this pregnant woman in your emergency room, if any? B?
B.
Okay, B. Okay, sorry, I can't hear. Okay. Anyone else want to give her anything else when she's pregnant?
C.
C. C or E? Okay.
D.
D. We could hear her last time. But no one wants to hear her gentamicin, so that's good. Great, okay. So then before you do that, she also has her 3-year-old son who has similar symptoms. He has a rash, he looks sick. So now I'll ask you, you have a 3-year-old who's in your ER with a pregnant mom, both presumably with Rocky Mountain spotted fever, big outbreak for North Carolina. Which of those things would you give to the 3-year-old?
D.
D?
B.
B, okay, sorry.
D.
Can't hear well. Okay. So B, and then someone say anything else? Okay, okay. Presumably he's 3. Okay, great. So Rocky Mountain spotted fever, this is probably of the things other than an asplenic patient with babesia that we would fear most in terms of the things I'll talk about today. This is a life-threatening illness. Most of the sort of deaths occur in the first 8 days of illness. So it's a rapidly progressive illness. It requires clinical recognition because you're never going to get your serology, your PCR back in time. You have to kind of know what you're looking for. It's endemic throughout the U.S. We've had a case in Vermont. It's mostly in those 5 states, North Carolina, Oklahoma, Arkansas, Tennessee, and Missouri. The rash tends to be a maculopapular rash. In patients who have a petechial rash, that is a risk factor for severe disease and indicates probably rapidly progressive disease, and people can develop digital gangrene, just like they can with Neisseria. And the biggest thing to think about with Rocky Mountain spotted fever, I luckily don't have to see kids, but deaths by age group, so kids are at the highest risk for death or severe complication from Rocky Mountain spotted fever, and like I said, it's in those first 8 days. So recognition is important and treatment is important. And I will say that we are seeing more and more Rocky Mountain spotted fever in parts of Mexico and Central America. So this was from Lancet ID in 2017. And so something to think about in returning travelers, if they have a clinical presentation that looks like Rocky Mountain spotted fever and they came from parts of Mexico, that should be on your differential as well. And at least in what we see in Mexico, they have a high case fatality rate, but I think that has a lot to do with early recognition of the disease and not necessarily a more severe or virulent form of the disease. So what about doxycycline in pregnant women, and what about doxycycline in kids? I do have to treat pregnant women, unfortunately, sometimes, but I don't have to treat kids. But we do know, so this was a review from last year, I think, looking at the use of doxycycline in kids and pregnant women. And at least the data for doxycycline, you can see, which is the second thing the table, there really wasn't a significant difference in the risk of congenital malformations between the women who were treated with doctors and the women who weren't. And that was data that was published in 1997, so it's old data, and it's Hungarian, it's from a Hungarian review where they did paired controls of 32,000 pregnant women compared to 32,000 pregnant women who did not receive doxy versus who did. So at least in their review, they saw no increase in congenital malformations. And we're talking about 5 to 7 days of doxycycline. It's a really short time. And again, this is another review looking for women who received it for bioterrorism issues. And so the doxycycline group, there was really looked no different than really any other antibiotics. And the doxycycline group was based on about 1,800 pregnant women. So I would assert that for a life-threatening infection, short duration, pregnant women and kids, we should be giving them doxycycline. The only other alternative is chloramphenicol, which is hard to procure for a lot of us, and doesn't work as well. And we do know there's great data to say that people that have Rocky Mountain spotted fever that got any other antibiotic other than doxycycline have a statistically significant increased risk of death. These are the consensus statements, at least in terms of pediatrics. We know that the tooth staining was really based on the older tetracycline formulations, and there's a great study coming out of Fort Collins, Colorado, from the CDC group there, saying that kids, even under the age of 3, that have had multiple courses of doxy, don't have any risk of tooth staining because we think it was the older tetracycline formulations. So even in kids that need a 21-day course for Lyme, most people are giving doxycycline and not amoxicillin regardless of age. Okay, so I have 2 minutes left, so I think do questions or do one more case. Okay, paper says case. So 36-year-old man comes to the ER with this ulcer-related lesion on his hand. This is not the patient's hand. This is a picture I stole, but this is an actual case. He notes it's been there for several days. He feels mildly ill, low-grade fevers, just kind of crummy, and he has a swollen axillary lymph node on that same side as his finger. And he says, yeah, a couple days ago it didn't look like this. It sort of had this weird sort of eschar. He's in the Forest Service. He's outside all the time. He doesn't recall any animal contact. He lives where I live in Addison County, down near Middlebury. He said, no overseas travel, nothing exciting. I'm just out in the woods all day doing my thing. So this is not, again, a picture of what it looked like his particular finger, but you can imagine this little eschar, and then it progresses to that ulcer, and that's really classic for this disease presentation. So which of the following do you think is the most common or most likely etiologic agent of this patient's ulcer and symptoms? Anthrax, MRSA, Lyme, or tularemia? We know it's not C. And hopefully it's not anthrax, because then you definitely have to call me, and that would be bad. So this is tularemia. This is one of my favorite tick-borne illnesses, and it's important to remember. People think like, oh, there's tularemia. We actually had several cases in Addison County, where I live, a few years ago, and it's spread by flies, mosquitoes, ticks, ingestion of infected water, or even contaminated food. So it has multiple modes of transmission. The most common presentation is just what I described, is what we call ulceroglandular, meaning you have an ulcer and then you have an associated lymph node swelling. Most common form we see in kids, common form we see in adults, and it's usually tick-borne. Glandular is just most of the kids get just sort of lots and lots of adenopathy and don't feel well. It looks like toxo, it looks like mono, it looks like acute HIV or CMV. It's really not specific. This oculoglandular is often people get splashed in the eye with contaminated water or rubbing their eye from a contaminated bite, and then you get like a skin ulcer and then conjunctivitis and ocular symptoms. It's called Paranode syndrome. It's very rare. We don't usually see that. Typhoidal is rare, but that's when people are at DIC in the ICU. We can often recover the organism from the blood culture. And the other cases we had in Addison County were pneumonic. And it's usually farm workers, lab workers that inhale it. And what happened in our 2 pneumonia cases in Addison County was these men were just innocently out mowing their lawn. And if you live in a rural area, there are rabbits and there are rabbit burrows, and they both mowed over a rabbit. and aerosolized the burrow and the rabbit and inhaled it that way. So careful with lawn mowing. But yeah, so you probably at some point will see the ulceroglandular form. It's pretty non-specific, but if you think about it and you ask the right questions, you'll come across it. Hopefully less commonly later on it. It's on the decline, but I will say in terms of endemicity, it's everywhere in the U.S. except Hawaii. So if you practice in Hawaii, you don't need to know anything about this, but if you practice anywhere else in the U.S., you should think about it. Treatment is doxy or Cipro, but for more mild disease, we're using streptomycin, gentamicin, or if you can obtain chloramphenicol. It's a clinical presentation. You can check serology on your patient, but it's sort of a paired serology, meaning at the time you see them, and then later you would start, just like everything else, you'd start treatment before you probably have the diagnostic testing back. And we do sometimes see positive blood cultures in people that have the type 4 or the Lyme form. That's it. So I won't go into the other cases. I'll stop time-wise and take questions, etc.
Did I hear you say that you are going to doxycycline first line for kids for Lyme disease?
I don't treat kids, but the CDC Fort Collins group says that even for a 21-day course for kids, they do not see any devastation. So a lot of people will use doxycycline for Lyme, and even in young kids. I think we're still using doxycycline